1, 2. Oh, it works. Right. Good afternoon, everyone. Good afternoon, everyone. All right. I promise we're not in here alone. Good afternoon. The Durham Public Schools Board of Education special meeting is now in session. At this time, we wish to extend a warm welcome to everyone who's joining us. The purpose of this meeting is to inform our parents, students, and constituents about the work aligned with our mission. Tonight, the administration will be presenting information to keep you up to date on where we are with our COVID protocols. We'll be meeting with the ABC Collaborative. The interpreter for tonight is Martha Romo Yugiles and Marty Ramirez. Thank you for taking the time to join us. The first item on our agenda is a moment of silence. Thank you. The next item on our agenda is agenda review and approval.
I'd like to add a proposed bus driver pay scale increase.
Right, so we'll add that right after, make that like a 4 or item 5 and make adjournment number 6.
Yes.
All right.
Move approval of the agenda as amended.
Second.
So moved by Ms. Byer, seconded by Ms. Valladares. We will do a roll call vote. We'll start with you, Ms. Byer,
Aye.
Ms. Lewis,
Aye.
Mr. Sears,
Aye.
Ms. Valladares,
Aye.
Mr. Lee,
Aye.
and Mr. Raven.
My name is Frederick Raven. I vote aye.
All right, it passed. And I vote aye as well. It passes unanimously. Mr. Raven is joining us virtually tonight. The next item on our agenda is we're going to be hearing from the ABC Collaborative, and the doctors, I believe, has a presentation for us. They are also joining us virtually. Dr. Mabinga, did you have words before we got started?
Just want to take this opportunity to thank our doctors for joining us. It was really such a short notice. They made themselves available. So just wanted to say thank you.
Would you like us to get started?
Yes, please.
All right, David, are you able to run your slides? Oh, you are still muted, by the way.
Good. Do you want me to share my screen, or do you have the slides and want to put them up? Which do you prefer?
I am unable to share screen, so if you don't mind doing it, that would be good. Or if someone could help us.
Not a problem. Let me share my screen. So the host needs to allow me to share the screen. It says it's disabled, and I'm happy to share my screen if whoever is the host will allow that.
So you should be able to share your screen at this time.
Yes, that is correct. Thank you so much. I will do that. Can you see my slides now?
Yes.
Yes, we're seeing the presenter view though.
All right, let me fix that. That better? Good.
Yeah.
All right. Thank you very much for the opportunity to talk to you. I'm representing the ABC Science Collaborative, which is a collaborative between Duke and UNC and other partners. I appreciate the opportunity to talk to you today. I'd like to talk about the mitigation strategies for K through 12 schools, including receipt of a COVID-19 vaccine as a condition of employment. By way of introduction, I'm David Weber. I'm the Saunders Distinguished Professor of Medicine, Pediatrics, and Epidemiology at the University of North Carolina at Chapel Hill, and I serve as Associate Chief Medical Officer and Medical Director for the UNC Medical Center. This is what's driving that huge number of cases. I'm not going to show you. We're all familiar with the number of cases. It's the exponential rise in Delta variant. You can see here the CDC data. that it now accounts for more than 97% of cases throughout the United States and virtually 100% here at UNC. This variant has increased transmissibility spread. It does have, I think now we could safely say, also increased virulence. That means if you acquire it, you're more likely to get sicker and be hospitalized or die. It does decrease protection from vaccines somewhat for symptomatic infection, but there's continued good protection against serious disease and death. Just looking at our data today, by the way, at the hospital, I noticed that 83% of our patients who were in the hospital are unvaccinated. 87% of those in the ICU are unvaccinated, and 100% of those that have died in the last few months have been unvaccinated. Of those who were vaccinated and end up in the hospital, almost all of them are immunocompromised, such as an organ transplant. Elimination of mask mandates in many locales throughout the United States, vaccine hesitancy and resistance, and as you know, substantial numbers of the population remained unvaccinated, holidays, 4th of July, summer activities, and to a lesser extent, breakthrough infections in fully vaccinated people have all led to this large surge in cases. This is some data, by the way. People have asked what impact we're seeing in children. This is the impact here at UNC. You can see in the orange bars the total number of cases and the percent to positive in less than 18 years of age. And you can see here over time that children are becoming a larger percentage of people who we're seeing in the hospital. One, because under 12, they're not vaccinated, and two, because of summer activities such as camp and others and the virulence of the Delta variant. So that is important to keep in mind. This is what we call the Swiss cheese model for protection against disease. And the idea is for any one of us to become infected, there have to be multiple things that happen. So, of course, vaccines are fully protective in most cases. And if they're not, they ameliorate the disease. So if you're unvaccinated, you don't wear a mask, you don't physical distance, you are in a large group of other people, at least whom one is infected, particularly indoors for a long period of time, then you're at higher risk for COVID. Some of these are personal responsibilities, such as masking. And as you know, CDC and many counties in North Carolina now state that you need to be, with some exceptions, masked when you're indoors. If you can't be masked, the best protection, particularly if you're unvaccinated, is physically distance, ideally a minimum of 3 feet, ideally at least at 6 feet. But again, the best prevention mechanism we have is vaccines. And then some of them, like vaccines, are shared responsibilities in that if you're unvaccinated, you're not only putting yourself at risk, but you could get a breakthrough case, bring it home to your children, your loved ones who are immunocompromised or unable to be vaccinated. What about the mitigation strategies that are supported by high-quality scientific evidence? We already mentioned vaccines supported by more than 100,000 people in vaccine trials. And unlike previous vaccine trials, those trials had approximate the same percentages of disadvantaged groups in them, specifically African Americans and Latinos, as we have in the U.S. Population. The safety trials ongoing still, showing that this vaccine is similar to other previous vaccines, and effectiveness trials out in the real world, where we now have tens of millions of people who've been immunized and studies the vaccine is highly effective. Masking while in school by students and staff is also highly effective. It was effective before vaccines and remains obviously effective now. It's supported by laboratory studies showing that if you are infected, that you don't expel infectious particles if you have a mask on, and by studies showing if you're uninfected, wearing a mask protects you from inhaling them. Case control studies, meta-analyses, and studies, in fact, that I'll show you in K through 12 schools. Physical distancing has also been demonstrated to be important, particularly when not masked. Outdoor settings have lower rates of transmission, and that's been well described. And then we have just the standard things that work for COVID, SARS-CoV-2, just like all the other respiratory viruses like flu, hand hygiene and surface disinfection. The virus does live on surfaces and hands for a period of time, but is easily killed by the alcohol waterless washes or by surface disinfectants. Contact tracing with isolation or quarantine, routinely done for infectious diseases by the local public health departments. Wellness self-checks prior to coming to work, where if you're positive, stay home and call your occupational health is certainly important, although I will note that doesn't eliminate, even if it was perfect, which it's not, because about 40% of people with COVID are asymptomatic and can be infectious, and people can be pre-symptomatic and still be infectious. Certainly, there are scientific rationales for plexiglass barriers or improved or enhanced ventilation, but there is still lacking good scientific evidence of benefit for those methods. Now we'll talk about one early study done, a pilot study. Many K through 12 schools began offering in-person learning and adopted strategies that we just talked about to limit the spread of SARS-CoV-2. Two-week pilot investigation of K through 12 schools in Missouri was done at the end of 2020. Schools in both locations implemented mitigation strategies. Springfield, however, implemented a modified quarantine strategy, permitting student close contacts less than 18 who had school-associated contact with a person with COVID, met masking requirements to continue in-person learning. School-based secondary transmission involving 37 participating students, teachers, and staff were identified with only 2 of the 102 tested close school contacts being positive. Again, masks and physical distancing work. Keep in mind this is before vaccines. No outbreaks were identified in participating schools, despite the 2-week cumulative incidence of 711 COVID cases per 100,000 people, and one county and then 1,000 in the other. So clearly circulating disease in the community, but not in the schools. And then we have some of the work coming out of the ABC Collaborative. My colleague on the phone and I were both co-authors of this, but Dr. Zimmerman was the lead author. This was a study of secondary transmission in participating school districts in North Carolina from August 2020 there to October, so the end of 2020. 11 out of 56 school districts were open for in-person instruction. Over 9 weeks, 11 participating school districts had over 90,000 students and staff in person. These students and staff, 773 community-acquired COVID cases were documented by molecular testing and through contact testing. Another 32 infections were acquired in the schools, but there were no instances of child to adult transmission of SARS were reported within the in the schools. And you can see that the rates here from the all North Carolina counties and the rates in the North Carolina counties in the study, but then the actual numbers in the schools showing much lower infection in there. And then our most recent study, more than 100,000 students and staff from 13 school districts, roughly 5,000 community cases, an additional 209 infections among 26,000 close school contacts. So the secondary rate in schools, again, remarkably low, less than 1%, with approximately 1 school-acquired case for every 20 primary cases. That's shown here within schools. You can see primary infections, meaning community-acquired, secondary infections, virtually non-existent. And then if you look at the pre-surge and post-surge rates, despite the surge that we had in the January-February time, the schools were protected, elementary and middle schools. There was some post-surge, an increase of cases in the high schools, but that was all related to sports that led to transmission. And when you remove sports, the rates were much lower. Again, the mitigation strategies we use in schools work. But the best mitigation strategy we now have are vaccines, particularly with the Delta variant. This was a multi-society statement for healthcare personnel that was adopted by many different societies, and for which I was the lead author there. You can see many, many institutions, including UNC Health and Duke, for instance, have adopted this as a requirement among all the individuals in their healthcare facilities, and many universities, more than 700 universities, have adopted mandates for their staff and students, including Duke. So what's relevant here? Well, the vaccines are available in the U.S. under FDA emergency use authorization. And I will point out to you, just within the last week, the Pfizer vaccine has received full FDA approval, having met all the safety, duration of protection, and effectiveness of all other previous vaccines. They are very effective to prevent symptomatic disease and even more effective to prevent serious COVID, even with Delta. And the good thing about vaccines are that they're passive. Once you've had them, then if you forget and slip up, where masks require constant attention to making sure you're wearing it properly. Now, I don't want to say because you're vaccinated, you don't need masks, because you do get breakthrough infection and can infect others, which is why CDC and the counties now recommend that even if vaccinated, you should be wearing masks indoors. These vaccines have similar safety profiles to other vaccines we use: mumps, measles, rubella, tetanus, diphtheria, and others. Full vaccination offers several advantages to students and K through 12 staff. First of all, it protects everyone over 12 from certainly having serious disease, hospitalizations, and deaths, and largely protects you even from becoming infected. It not only protects you, but if you don't become infected, you can't bring disease home to children under 12 or transmit it to children under 12 in the hospital. Even if you're not masked and they're not masked, you've dramatically reduced those risks, although you should stay masked, as I've mentioned. And for immunocompromised people, including students and staff who might have cancer and undergoing chemotherapy, reduces their risk. We do know that, as I mentioned, a large number of people are asymptomatic but infected, and obviously the vaccine tremendously reduces the risk of their becoming infected and unknowingly transmitting disease, and protects their households and loved ones. Here's just some data on how well, compared to the Alpha, the earliest variant, and Delta, how well the vaccines work, and from England, Scotland, Canada, and Israel. I do want to point out that when you look at a confirmed infection, that the vaccines look good. In Israel, you can see they're not quite as effective against confirmed infection or symptomatic disease. It's hard to disentangle whether this is Delta or whether this is in part that Israel began their vaccine campaign much earlier than others, or it may be an issue of the way they're doing their studies. But this is one of the things leading the FDA to consider giving boosters for all people after 6 or 8 months after their vaccine. But I want to point out to you that all three studies show how well effective, 93 to 100%, even with Delta, this vaccine is keeping you from being sick enough to be hospitalized or dying, which obviously should be foremost on your minds. I do want to point out to you that now the American College of Obstetrics and Gynecology and Society for Maternal and Fetal Medicine both recommend that all pregnant and lactating individuals can safely, not only before they said benefits exceed risk, now they say explicitly they should get the vaccine because pregnant women have a higher risk of serious outcomes, and nothing is worse for their fetus than for mother to get sick. And more recently, CDC has said exactly the same thing. In addition, there is no evidence that any of these vaccines affect fertility in men or in women. So requiring a vaccine is not prohibited under the FDA emergency use authorizations. It's not prohibited by federal law, and it's not prohibited by North Carolina law. You have to pick a final date for compliance and a mechanism for appeal. You should accept medical contraindications as listed by the Centers for Disease Control, or FDA. You do need to accept religious objections, but those can be screened to make sure they're valid. You may choose to allow pregnant women to defer, although I've already told you the best medical advice from the experts is they should be immunized to protect themselves and their unborn child there. People who have had natural COVID have a somewhat disordered immune system and should receive the vaccines as recommended by the CDC. Immunocompromised people are now eligible to get a third dose of a vaccine. One might consider, as many universities and hospitals are doing, that unvaccinated people who have an exemption should be tested weekly for COVID, since they're at the highest risk. And at the present time, because of our high circulating numbers, people, even if vaccinated, should adhere to all the other recommended mitigation strategies. This was a nice paper in the New York Times that looked at the 4 different reasons why people are vaccine hesitant. Some are just waiting to see what happens next. That group, which was at 50% in December, has shrunk noticeably, and I expect, particularly given the FDA approval of the vaccine and the rise of Delta, that will continue to shrink. Some people are cost conscious, but the vaccine is free, and we need to make it more available to them so they don't have to miss work, or if they have side effects, we cover that. Some are just system distrusters, and one can certainly understand some of that with Tuskegee and other issues in the past. You need to engage trusted members of their own communities to their concerns, and you need to be transparent. And then there are the numbers who are just COVID skeptics, and really attacking them and trying to debunk their beliefs is not the way to go. You need to have them understand it is a personal choice in most cases, but they need to get vaccinated to protect friends and family. You can't watch a television news report now without seeing somebody who has their husband, wife, or child in the hospital saying, if I only knew that they could be in the hospital and possibly die, I would have gotten vaccinated, and I would have had them vaccinated as well. And then finally, I just want to thank you all for what you do. Teachers and staff in the school systems are heroes for all you do to both protect our children and teach our children. So thank you very much. And of course, as my colleague is, we're happy to answer any of your questions.
Thank you so much, Dr. Weber, for that presentation. We'll open the floor now to questions, board members. Ms. Valladares.
Thank you so much for that presentation. It's definitely very reassuring to hear about other institutions that are implementing vaccine mandates following all HR and legal requirements. I was really interested in the slide that says vaccine hesitancy. I knew that I really appreciate the breakdown of the people who are waiting for others to do it. I think that in that sense, vaccine mandates might be able to encourage folks who were thinking of doing it later from doing it like sooner. Mistrust, which is definitely something that I think institutions are working on, how to increase trust and all that. So a lot of kudos for the breakdown of all that. I'm wondering if you have any suggestions on, the term vaccine hesitancy has been debated here or there, because sometimes they're like, there is hesitation, but it's not just about the vaccine. And so when it comes to especially marginalized communities, whether they are Latinx or Black communities, there are a lot of efforts towards kind of meeting people where they're at, and not just saying that it's a vaccine hesitancy, but maybe these other factors, whether it's like, I loved how you broke down that, it could be the time and the effort, and that's where institutions need to work with folks so that we can, give permission or give accommodations for folks who during the workday, have to go get their vaccine. So I'm wondering if there's any recommendations that you might have about a term that puts more of the omen on institutions to kind of meet people where they're at, and not just the vaccine hesitancy, but more of those extenuating factors that sometimes affect folks' ability to get their vaccine.
Yeah. In the document, which I didn't have time to go over, I was the lead author on, but had many, many experts in it, we do provide a number of evidence-based practices that do increase, limit the hesitancy and help it. Among them, as you've already mentioned them, providing vaccines at people's close working place, that is ideally providing at the school, if not providing time off for people to get vaccine paid time off, certainly providing, not in any way disadvantaging them if they miss a day or two of work from side effects, covering that as well with paid time off for that. All of those and having good, hours that people can get vaccinated that are frequent. All of those are certainly helpful, and we have had great success not only with our vaccine centers, but with a mobile van that brings it to communities that have trouble financially taking time off or just visiting and waiting online at a vaccine center. Having people who can help enter the data that you need to into the state CVS system, CVMS system that's required, so people who are less able to manage computers is important. Having vaccine information to people who only speak Spanish and all the information available as well as translators are important. And then dealing with the questions for which we do have answers. Do the vaccines affect fertility? No. Do the vaccines, have they been, is there any evidence of harm to pregnant women or fetuses? The answer is no. Are there rare serious side effects? Yes, but they're no more frequent than any other vaccine. And when you know that roughly 650,000 people in the U.S. have died of this, both last year, and I just looked up the date in August, COVID is the third leading cause of death in the United States, surpassed only by cancer and heart disease, so way ahead of things like automobile accidents and things that we worry about, lightning strikes and sharks and all the other things, suicide, homicide, things like that. People have to understand all the benefits in protecting them. We have to talk to them on a one-to-one basis, and I've mentioned it's key that they hear it from members of their own community who they know and respect, and that is the best way to do it. I don't want to lump in all disadvantaged communities because Native Americans have a higher rate of acceptance of vaccine than white individuals there, but I can certainly understand the hesitancy in other marginalized communities in the past. So to the extent we deal with it, I will say we've had a great deal of success in the vaccine hesitancy. People have questions that they weren't answered, but the truly resistant group of about 20% has not changed, unfortunately, since December. Although interestingly enough, when you ask that truly resistant group if the vaccine were mandated, would they get it? A substantial number of those, more than half, actually say yes. So that is one way of overcoming the truly resistant group. And I'm sure my colleague will have some comments as well.
Thank you so much.
I don't think there's a perfect term. I completely agree. I think vaccine hesitancy was used to capture most of the population you described. It could be sort of people with lower access to vaccines, but you've highlighted all the different ways, including school-based vaccination efforts to help reduce the pool of people that may just not have been able to get vaccines, although they're interested.
I really appreciate that. I have seen videos that have come out, especially you mentioned, our tribal nations, First Nations in the state. And I have seen some YouTube videos where folks have come out, faith-based organizations. That is huge. There's actually a video out there on YouTube where it's from all the different tribes in North Carolina, and they're all faith-based ministers. So it's like the intersectionality of organizations that are faith-based, come from marginalized communities or historically underrepresented communities in these efforts. And so I'm very appreciative for all that you shared tonight. And I guess the work continues. I've seen some of you showing up to the African American response for COVID and Latin 19 and some of these other groups, which that's the work that it takes to continue doing that, and also working with some of the nonprofits and some of the community organizations and faith-based organizations at that. So thanks for all the efforts.
Thank you, Ms. Valladares. Any other questions from board members? Ms. Byer.
Dr. Weber and Dr. Kabu, thank you for joining us, and thank you for joining us on such short notice. I really appreciate your expertise. I appreciate how you all have walked as partners with us in this difficult journey and helped not only school districts in North Carolina, but all over the country. Your work has been remarkable, and we are proud to have you as Triangle residents and Durham folks. As we look towards a vaccine mandate for our staff, the model that you all have implemented at UNC, is that a model that you think would be able to successfully be shared with us as we contemplate these decisions for our own employees? Are there any special considerations that you think school districts should keep in mind that are different from what you all have done in the healthcare setting?
There are some, obviously, but I will say both Duke and UNC, speaking for both medical centers, are more than happy to share any of the lessons we learned and materials. An example will be is we do have a sheet at the UNC, which I'd be happy to share, developed by our occupational health director, Dr. Erica Pettigrew. Not only runs our occupational health service, but is also the medical director of the Orange County Public Health Department. That allows an employee to check whether they have a medical contraindication for which they would have their physician sign, or whether they have a religious objection. We have two separate groups, one that mostly legal and human relations that review the religious objections, and we have a separate group of physicians that reviews the medical exemptions. And you could set up something similar there. I should say we do include in those groups both ethicists and diversity experts, so that we want to be as fair as possible. And there is also an appeals process, so we can certainly share some of those materials and lessons. You want to be as transparent as possible. I think that's key. As you begin implementing a decision, as you discuss making it, you want to engage people at all levels within your workforce, from your principals all the way down to your environmental service workers and others in this, as well as obviously parents. You want to be transparent. You want to hold question and town halls, much like we're here holding an answer session for you. And I'm sure through ABC, we'd be happy to have a larger town hall that would answer questions about vaccine safety, effectiveness, and others for all the workers in the system. And you want to set realistic timeframes for achieving success.
Yeah, I appreciate that. I think the date that Duke had set was October 1st. Is the date similar at UNC? Have you all set out a similar timeline?
Our date is a little more ambitious. It was September 21st, and so and that's for completion of your vaccine series. So actually, today would be the last day you could receive a Pfizer vaccine and still meet that deadline. Obviously, they could get in the next 3 weeks the Johnson & Johnson single-dose vaccine, but this would be the last day to get one of the mRNA vaccines. So September 21st is our final date for everyone being compliant with this policy. And I should say this is not new for us, by the way. As new vaccines have been developed and feeling we have a high burden to our patients, mumps, measles, rubella, varicella, the pertussis vaccine, and influenza vaccine are all required as a condition of employment at UNC.
Thank you. I think it's so important for us to consider how we do this with our employees and walk hand in hand and answer all their questions along the way. So I would love seeing your models and what you all have learned as best practices. The thing that we are struggling with as well is surveillance testing. Have you all found best practices for that, especially with school districts nationwide? Is there advice you can give us in that realm?
Yeah, I can weigh in on that. So as you might know, we've worked closely with some charter schools to perform surveillance testing, but oftentimes it's under the umbrella of very clear testing goals. We know that in certain populations, for example, some of our athletes, we've seen higher rates of spread And surveillance testing helps to capture asymptomatic infections and reduce the rate of spread. Also, we've seen that happen within some of our special needs communities. On a larger scale, I think when people think about surveillance testing, particularly with Delta variant spreading, they also just consider testing a portion of the school or everyone in the school every so often, so on a scheduled cadence. It's important to note that if you're not capturing a good proportion of the school community, you're likely just getting a snapshot in time that may not be as useful. And the plans for testing, follow-up, and tracing potential contacts have to be in place before this is started. So that's sort of a longer way of saying there may be some utility in exposure testing and diagnostic testing. If someone's a close contact, you can immediately get them a test. If you're trying to figure out quarantine or modify the duration of quarantine, you need fair, easy, and equitable access to testing. And as Delta is spreading, there may be a role for surveillance, so scheduled testing, but there needs to be a lot of clarity around what that testing goal is and how the testing results will be applied.
Can I ask a clarifying question on this point? You said if you're doing surveillance testing, you need to have a portion of the school. Can you restate what you were saying about that?
Yeah, Ms. Umstead, I heard a part of that, so I'm gonna just make sure I'm repeating the question. You would like me to clarify what I said around surveillance testing and how it's sort of the portion of the school, is that correct?
That's correct.
Okay, yeah, so surveillance testing is so the definition is performing a test, usually in a portion of the school attendance, so school students or school staff. You can do it on everyone that walks into school that day, but that's largely impractical. It's just nearly impossible to test every single human that walks into school. So people usually try and capture a portion of the school community. But if you only capture, say, 2%, that may not be really reflective of the potential spread in your community. So you have to calculate how many people, if I have 100 people that come in every day and I'm only going to test once a week, how many people do I need to test per week to sufficiently capture any asymptomatic infection and ensure that they're removed from in-person schooling? Again, this can be done and can be done safely, and we've seen that done in lots of communities where it has had some utility, but most often, if you're only testing a small number of people, you find a lot of negative tests, and it is resource heavy without without a lot of utility in the school setting. It's useful, but you have to have a solid plan before rolling it out.
Thank you. That was helpful. Ms. Barr.
So what about the idea of rapid antigen testing for our families to have at home when they have a child that isn't just feeling off and as a quick rapid check? Is that useful at all as a part of a strategy?
So let me take that first. I'll see if my colleague says it. I think certainly the rapid tests are never been demonstrated very accurate in asymptomatic individuals. The rapid antigen tests are best used for routine periodic testing, as we've seen in some universities, some K through 12 schools, sports teams, and others. Certainly, if it's positive, you would not want that child to come to school. You'd want them to go to be seen by a licensed practitioner and be retested to see if they truly have COVID, because there are therapies, depending upon their risks, that might be provided. But if they're symptomatic and the test is negative, I don't know that we would, one would automatically assume it's a true negative, and that should still be, if they're symptomatic, they need a PCR test. So I think it's of some use, particularly if somebody's at home and they're thinking about whether they should visit, a grandma that night, but not really as a mechanism for deciding whether they're a staff member, teacher, or a student should or shouldn't come to class. If they are symptomatic, they need to see a physician or other licensed practitioner and be tested. If they're asymptomatic and exposed, they need to follow the CDC guidance.
Thank you so much. I have more questions, but I'm going to let my colleagues jump in here because otherwise I will take all the time. Thanks.
So excuse me. Thank you, Drs. Weber and Kalu. I just want to make sure I understood what was presented. I think what I saw in the entire data presentation was that all of the outcomes that you showed were related to being fully masked. Is that correct? With the low transition rates of 1% and 2%, those were all studies where everyone was masked at all times?
Those were studies where the policy was that everyone should be masked at all times. We never achieved perfection. That is, when people have actually monitored people in the school systems. Many of those school systems had excellent compliance, meaning over 90%, but that doesn't mean every single child and every teacher was always masked at every time. But yes, that's the goal, and you're absolutely correct.
Okay, I think I'm going to ask a question that I know the answer to. It's in the school toolkit, but is it your recommendation, given that all of this is related to masking, that, I mean, this board stated to our administration that we should be pushing when possible to be eating outdoors at all times. Is it your expert opinion that we need to be pushing hard on that? I mean, without caveating it with all the difficulties of doing such a thing, just as the scientific experts, should we be pushing to be doing all eating not in closed spaces?
So obviously, if you're eating and drinking, you can't wear a mask. And so your only protection besides vaccines then is physical distancing. And it's clear that being outside at the same distance inside is better because you have more dispersion of the infectious particles, a larger volume of air, winds that carry them away from people, ultraviolet light from the sun that just helps destroy the virus. So being outdoors compared to indoors is superior. And clearly, maintaining physical distancing, even if outdoors, ideally 6 feet, but minimally 3 feet when eating, would be advisable.
I just want to add one other point.
The same thing true indoors. That is, outdoors is superior to indoors, but if you have to eat indoors, then physical distancing to the extent possible is superior to not physical distancing.
Yeah, and I agree completely. I wanted to just highlight one other quick point, which is sometimes it's less about almost focusing on the location, but focusing about the risk of spread. So we've shown data and we've seen data that consistently supports low spread in school settings, but it involves masking and some of the other things we've mentioned. The highest risk of spread occurs when everyone takes their mask off. And so one way to reduce that risk is by moving outdoors, and that immediately drops, and we're not including numbers here, but immediately drops the risk of COVID-19 spread within that group. And so that's why we've encouraged school leaders to push for outdoor settings during any unmasked activity. Could be lunch, could be snacking, it could even be sports. Yeah, some athletic events have to be indoors just by nature of the event. But for every other thing that can be feasibly occur outdoors, we should push for that.
Okay, thank you. Forgive me as I try to wrap my head around some of these things. Do we have data on deltas, the frequency that non-vaccinated or children, whatever breakdown we may have, that folks that acquire the virus do show symptoms? Is there any data out on that?
Yeah, I can wait. And again, I'm going to repeat the question because I'm having a little bit of difficulty hearing everybody. But it sounds like, do we have data on the
rate of symptoms in for all of those that acquire Delta, the rate that they actually demonstrate symptoms?
Got it. So we have data that's parsed out according to vaccination status. In general, we see, we can toss out some numbers here, but we see lower rates of symptomatic infections in those that are vaccinated as compared to those that are unvaccinated. In children, we see about 40 to 50% of kids that are infected with SARS-CoV-2 be asymptomatic or have really mild symptoms, such as a cough or runny nose that completely resolves in a few days. And that pattern has held true with Delta. I will say that we've seen a slight decrease in the asymptomatic rate in the recent weeks. It seems that Delta is just a bit more aggressive, and so kids show more symptoms, but still have short diseases and get better relatively quickly. For those that do, we still see some kids that unfortunately have worse outcomes, need to be in the hospital or die from the infection.
Okay, so apart, we know we're not perfect with the masking. We know we're eating indoors. We know because mechanical systems are not perfect that airflow is not perfect, right? We closed a couple schools yesterday because of such things. So, you know, while the studies show 1% and 2%, and they weren't perfect either, those are in masking settings. We know there's benefit to everyone being vaccinated for the reasons that the doctor stated in the data, and vaccinated, you know, ages 12 and up. But I think my question for the doctors is just, and perhaps you're not willing to, my question is, would a vaccine mandate for staff, would it likely over the course of this school year significantly, and I'll let you define significantly, reduce the number of potential spreads in our school? I mean, I'm hearing that if we're perfect, the spread is going to be low anyway. But given 2,500 teachers, would we expect significant reduction in COVID spread in our system if we did a vaccine mandate?
I believe you would. You will not only protect that individual teacher from getting COVID, but certainly we do see at the hospital that people are very good at wearing masks in the work situation, meaning when they're, like in your case, teaching the children, but then they tend to go during their breaks and lunch times when they have time to rooms and talk and gossip with colleagues and take their masks off thinking they're safe, and have, parties for people having birth or getting married. And we see transmission in the hospital with that. So that protects the teacher to teacher transmission. And as you know, there are, of course, some children, because of disabilities, unable to wear masks, and will better protect them. So the answer is yes. I think having a mandate not only protects the individual person, but will protect their other colleagues, staff, and students in school. And as we talked about the Swiss cheese model, it's much like why you have seat belts and airbags in your car, because if one doesn't work, it's good to have the other system, because they're additive in terms of the protection, as well as we build things now into cars like collision avoidance systems and roll bars and all sorts of other things, because they're all additive. You want to maximize your protection rather than counting on just any one device or feature to protect you. And the same thing's true in this case.
Thank you. I think my final question for now, if I could, is I've only seen the infographic. I have not read the report, but I believe it was out of California, the one teacher, one classroom, 50% infection. Doctors, have you seen that study, and can you give us the 30 or 60-second rundown and what that might mean for us? I think it just came out a couple of days ago.
Yeah, I can start, and then of course Dr. Weber can weigh in. It's a CDC report on a classroom. It ended up being 2 different classrooms, but they were able to trace the source of the original infection. It started, this was what was described, but it started with an unvaccinated and symptomatic teacher who was also unmasked, despite both I think California and the local district's rule for universal masking, and taught a class with the teacher's mask off, and that led to, over time, infections within the classroom it seemed to occur most often in those that were closest to the teacher. That's not surprising, but really actually occurred with those sitting just right around the classroom, which is not shocking. That's what happens with SARS-CoV-2. And then also spread outside of the school. So it impacted households or people that were tangentially related to that classroom. There was another classroom where they saw spread that was geographically separate from the classroom the teacher taught, and it was, I think, across the playground, clearly no cross ventilation, no potential for airborne spread. But there were a couple of kids that had a sleepover, and it's sometimes not clear how often kids within a same school may interact socially outside of school. So when they mapped out the infections, they thought that they saw similar viral strains spread into classrooms, but for the main classroom, it started with unvaccinated, unmasked, and asymptomatic, so person with symptoms teaching in a classroom, indoor setting, even when other people were masked. So what are the lessons there? I think we've highlighted multiple times that the Delta variant is more transmissible. You certainly need to layer up your preventive measures. And as you take out those layers, vaccination, masking, and indoor setting, you can see an increase in transmission, which has played out in this case. We also have kids that are unvaccinated. So even if they're wearing their mask with mostly high compliance, we need to layer up additional measures for our kids that are under 12, because that's a pool that's not going to have, they're not going to be eligible for a vaccine, at least within the next few weeks. Dr. Weber, did you want to add anything?
No, I think you've hit all the key points there.
Thank you so much.
Thank you. I guess just have a little closer. Okay. I have just a few questions. Thank you so much for your presentation. It's very understandable. And just even taking historical where you all began last fall with the research. And one thing that's been constant you all have shared is mitigating risk. And it's great to see vaccines being the first thing, showing the most proof to mitigate risk. On that slide you shared, there were a list of things to mitigate risk, and we want to layer those things in mitigating risk. At the very bottom though, and I missed what you were saying, with the shields and the air quality, were you saying that's the least likely? It's good to have that there, but it's not scientifically proven? I missed that very last.
Yeah, so there is, you're absolutely correct. There is a strong rationale behind mixing more air in, open windows, better filters to remove it, but that actually has not really been shown with studies, the many studies which we just talked about for masking and physical distancing and vaccines. An example of the case that was just discussed, which there was transmission in the classroom, they actually had HEPA machines, that is high efficiency particle machines, and open windows, and that didn't prevent infection. I think if you can do it, it's certainly worth putting in higher efficiency filters, but many of the older buildings, it can't be done, and certainly you can't redo your entire heating air conditioning system in a short period of time. Opening windows, you have to worry about fall risks depending upon how old the child is and the height of the windowsill. It may enter noise and pollutants into the classroom that may interfere with teaching. So those are further down the list. And again, plexiglass shields, really, because air flows around and over and under them, again, may somewhat decrease the protection, but if you're wearing a mask, that's the effective way. And having a plexiglass shield is not, without people on either side of it being masked, is not successful. So there is theoretic reason for doing them, but that's not the priority. If you can do them, I think it's fine, but the priority really, as we've mentioned, are the other wellness checks, keeping people home if they're sick, masking, physical distancing, vaccines, and the others.
I appreciate that. And I'm so, again, just very grateful that you all are on with us to answer these questions. I'm also very interested in the research that you were sharing about no instances of child to adult spreading of the virus back in the fall with the research. Has there been any updated research that still supports that? And also the lower infection rates within schools, again, mitigating risk in school work is what you said. Is there any updated studies about infection rate from children to adults or adults to children?
I can start off with that one. So that was our data from the fall. We also showed data from the spring during the winter surge, which started November, December into January and February. To clarify the point, children can get infected, can spread to each other, and can spread, so a child can spread to an adult. In the cohort we looked at that time, we did not see any child to adult spread. And a lot of other colleagues across the nation have replicated that finding, such that there's a lower rate of child to adult spread within the school setting, but they're fully capable of spreading infections to everybody. That's exactly what children do. In the household setting, that's completely different. Children can spread to each other and spread at a really high rate to parents as well. So we've shown some of that data, that pattern has remained, but I just want to clarify and emphasize that although the rates of spread within school is low, so the rates are low, but children do spread infections to each other and to adults.
Thank you for that clarification. Also, one additional question to the study and the research that's out there. When you are doing a study in the fall and then again in the spring, did you find that those schools were eating breakfast and lunch outside, or was there a mix between being inside and outside with other mitigating factors being included?
Yeah, as a reminder, so those studies are all from North Carolina. In the fall, most of those schools were in Plan B, and most of those included 6 feet distancing indoors and outdoors, and they did try to eat lunch outdoors. In the spring, a lot of schools shifted to Plan B and also Plan A, and they tried to eat lunch outdoors as much as possible. I have to go back to see if we measured how often that occurred. I don't think we actually included that in the paper. But for the most part, when lunch was provided indoors, it was in the setting of a lot more distancing. So aiming for 6 feet by moving the kids to the cafeteria or the gym in an attempt to just reduce the likelihood of spread when children take their mask off.
Thank you for that. And then I know that UNC and Duke are both looking to require vaccinations outside of certain instances. Do you know of any school, K through 12 school systems that are doing that yet?
Well, we know we start off within the triangle, so people have already emailed us about Orange County and some of the other counties that are considering this. We're certainly happy to provide information about the utility of vaccines and potentially vaccine mandates, but we haven't weighed in with all the schools considering this as to what their timeline might be or how soon they're going to make that decision. So Orange County is our local comparison right now, but most of our data regarding vaccine mandates have come from healthcare settings and universities. I know some of the larger school districts across the country are starting to consider this as well.
And thank you for the feedback. You also shared the information about not just mitigating risk, but also with surveillance testing. That was very helpful. I have a question that's nothing that you all talked about, but I'm getting a lot of parent inquiry, and it's about quarantining. So if there is a close contact and the child is unvaccinated, thinking of our 12 and under, then the requirement is that they have to be at home for 10 days quarantining. But if they are vaccinated, the quarantine time is different. And then my last question around that quarantine time, if a child tests positive for COVID, do they have to have another test in 10 days showing a negative test?
I may have to defer to Durham Public Health for the specifics of quarantine recommendations based on the setting. of close contact or infection. But we have state guidance and CDC guidance that support a fully vaccinated person getting a test after an exposure, but not officially quarantining. On the other hand, an unvaccinated child will be required to quarantine, and then the duration may be dependent on the test result. Just of note, if you are in quarantine and then you become positive, you are now infected. And so you go into isolation, and that's been a fixed duration of 10 days. So it may seem like it's a longer process for them. It may be because they shifted from quarantine to isolation. And once the 10 days are over, you can return to the school setting if symptoms are also improved, and you do not need a repeat test.
That was the main question. Would there need to be a repeat test? Excuse me, that was the main question. Would there need to be a repeat test afterwards? Thank you so much. That's all the questions I have.
I'll just add, yes, we no longer do any testing. People we know are infectious for 10 days who are healthy and out of the hospital. Sick, immunocompromised patients go on isolation for 20 days, but a test-based protocol is not recommended.
So just to follow up on that, is there can you all explain the 10 days? I think we've had some parents also say, my child tested positive, they felt better, could they come back to school? What is the 10 days? What does that kind of represent in this period?
What people have done is taken people who've become ill and then tested them. Initially, they were just looking for the SARS-CoV-2 RNA, but more recent studies then looked for viable virus, which you have to grow it in a special safety laboratory. And they showed that individuals who were not sick enough to be hospitalized or immunocompromised by the end of 10 days, even if the test remained positive, because it can pick up just the RNA, there was no viable virus in their sputum or their mouth. And so, and there have been many studies with hundreds of people for whom that's been studied. And that's what leads to the CDC and the other guidelines saying after 10 days, you are able to return. Now, you should be, when they say 10 days, the other caveat I should say is it's 10 days with at least 1 day afebrile and feeling improved, not entirely asymptomatic, but 1 day without a fever, not taking Tylenol or aspirin and improved. But almost everyone has that by the end of 10 days.
Again, just like everyone else, thank you both for being here, and I really appreciate this presentation and information you've given thus far. I did have one question. When you were initially speaking about what UNC has done as far as their policy, and that you may be able to share your lessons learned and information about that, you mentioned the need to provide exceptions, which is an obvious, for medical and religious purposes. My question is, in your opinion, is there any other interventions as far as protective if individuals are granted those exceptions? I would expect if an individual is granted, say, a religious exemption, they would still be as vulnerable, without a vaccine. Are there any other things outside of wearing a mask that we should prepare for in those instances in a classroom where someone can't be vaccinated? How can we add additional protections in those situations?
The things, one, would you, of course, always emphasize self-wellness checks, stay home if you're ill. And some institutions, different schools, workplaces, and others have tested those individuals routinely. And if you're going to do routine testing to be effective, it needs to be done at least once a week. And they focus their testing on those who are unvaccinated for whatever reason, as a way of picking up individuals who might be infected. Now, keep in mind, testing is not a prevention strategy. It's an early mitigation and control strategy. But beyond that, I'm not aware there'd be anything more specific that you could recommend for those individuals.
Thank you.
Right. Many of my questions have been addressed through the other board members' questions, but I do have a few. It sounds like what you all are saying, though, is a lot of the strategies that you talked about previously with masking and distancing, now the vaccine is an added layer, are still, even with the Delta variant, still the right protocols to have in place to prevent spread of COVID. Is that correct?
The simple answer is yes. And, if we'd been back, frankly, in April when the number of cases had fallen dramatically and CDC had said vaccinated people could be inside in certain situations without wearing a mask, we would have given you different advice. But given the high infectiousness of Delta, plus the dramatic increase of cases, which are still on the way up and will likely exceed the largest surge we had in January and February, yes, we need to use at this point, my view and many experts, is every mitigation strategy needs to be layered on. Of course, our ultimate goal is first to protect the health and safety of our coworkers and our children. And then by doing that, allowing those children to come back to school, which is clearly a crucial part of their well-being and advancement in society, taking in-person education, but doing it safely.
The other question I have is about breakthrough cases. And should we be concerned about folks who are vaccinated who may test positive for COVID and causing spread? Is that a concern that we should have?
So the answer is yes. Breakthrough cases do occur. I've already said they're dramatically lower in vaccinated people, but they do occur, and those individuals clearly are infectious. They're infectious for a shorter period of time, although we don't know how much less, and that's one of the reasons they still, once they're sick, they're out for 10 days. So vaccine does reduce the amount of virus they have more rapidly, even if they get infected. But yes, that does remain a concern, and that's why we've gone back to universal masking, vaccinated or unvaccinated.
That was the end of my questions, except for this one last. Can we make sure that the slides that you all presented today are updated on our website? If y'all could send them to us, I would love for that to be included. So folks who are watching the meeting later can also follow along with that information.
Yeah, one of us or both of us will send you the slides.
Right.
And from our standpoint, you're free to distribute them anywhere you would like.
Thank you. Ms. Byer, you have additional questions?
I do. I really appreciate it. I would say that one of my concerns about your early study that was so helpful, but was in more rural parts of the state, is that you were studying districts that were more rural, had extra room in their buildings, were not at full capacity typically, and clearly weren't with Delta variant. And so our parents are alarmed, as you can imagine, about the change in Delta, how much more transmissible it is, and how we don't have the ability to do 6 feet of distancing. So is there any insight you can give us? Is ventilation more important than we thought it was before? What else can we do that we're not doing? Because it is our goal to keep school going, but also not to have any secondary transmission. That still is a huge goal of mine as a board member of this district.
So I'll start off on that. The earlier study did have more rural districts, but we also, by nature of some of the laws in North Carolina, were able to work with 100 districts across the state, going from city to county-based school districts and some charters as well. So we were able to show similar results as alpha variant was spreading, so seeing community peaks, we were still able to show low rates of spread. But you're right, we're now seeing a more transmissible virus as we're headed into the winter or respiratory season, where we just see more infection spread. It's hard to say at this point that this next item is going to change the risk significantly. I think it's ensuring good adherence or good compliance with what we know already works. And that's why we've emphasized things like working outdoors and moving kids outdoors during unmasked moments. Ventilation is a big part of the safety of an indoor setting, but it really depends on what we mean by proper ventilation. We're not talking about major overhauls, but make sure you have adequate outdoor air coming in, adequate filters, and it's maintained as indicated. But it's hard to say this one factor now needs to be done. I think we've already optimized a lot of factors to prevent COVID within the school settings, and we've shown that it can be done. Even in an era of unvaccinated people being in school, we didn't have vaccines authorized at the time, and when we had multiple spikes in communities. So Delta is worse for a number of reasons, but we have some tools that can be used to ensure schools remain safe for in-person learning.
Thank you. And when Dr. Benjamin came to the Orange Board, he noted 4 rates of increased risk, and we've talked about some of them. One of them was athletics. One of them was students with exceptional needs. One was kind of pandemic fatigue. And I think we see that with some of our adults that get extra confident because they're vaccinated. Maybe they let their mask droop under their nose. I think it's going to be important for us to hear from you all as we help folks with pandemic fatigue. And then the other is eating close together, right? Pulling those masks off. And the logistics of that are incredibly challenging, as you can imagine. If you all are seeing best practices in any of those areas, particularly athletics, any of those areas really, especially as you look at the national landscape, anything you all can share with us would be so helpful, because this is all new, and it is yeah, it is new. And I don't want our employees who are vaccinated to feel a level of confidence from that because they can continue to transmit to our students. I should probably ask that in a question, but it's just what puzzles me. Can you also give us have you all heard anything about the timeline for pediatric vaccines? I know the American Academy is pushing for it to be done sooner by the FDA. Is there anything new in that area?
I can give you some update on that. So initially, Pfizer, Moderna, both of which are in phase 3 trials, had hoped to be able to submit in early to late October sometime, FDA approval or authorization for somewhere between 3 to 5-year-olds and 11-year-olds. But the FDA, and they had about 3,500 children in each group, each company. The FDA has asked them to double that amount. They have some concerns. They want to have a larger group to look at safety. That will push things back until something on the order of probably late October through mid-December. And then for the youngest children, 6 months to whatever the other age is, and there are already trials at Duke being done by a colleague, Mike Smith, and others, that probably won't be available until somewhere between January and July of 2022. So we will have likely boosters available for older people, but we won't have vaccines. We may have vaccines by the beginning of the winter time after the winter break for younger children, but it all depends on how quickly those studies can be done, and then ultimately the FDA view of the benefits and risks of the vaccine.
Thank you, Dr. Weber. I'm glad to hear that there are trials around the area, and I imagine that families might still be able to enroll in some of those. Athletics, anything with best practices for athletics, as we've had some issues over the weekend already?
We've often relied on educators and coaches to help with figuring out how best to apply the typical COVID mitigation practices there. I think in some settings, there are arguments that testing may work. Again, just defining the goal for testing. Is it surveillance testing? Is it just easier access to symptomatic or post-exposure testing, since exposures may be more likely to occur within athletics. And it's not all athletics. There've been some, for example, wrestling, that have been identified as higher risk of close contact during the sport and higher risk of spread. So testing may be something to consider, and vaccinations in whichever form. So requiring, recommending, strongly suggesting would be helpful for our athletes.
Thank you. And a parent emailed today about choral music and band needing to be outside. Is that revised in the cool toolkit from the state as high-risk activities?
If it's considered high risk, we've not particularly shown data around that. I would have to reach out to my colleagues to see if we've collected that specifically. I think music educators, dance and art teachers have also been very resourceful in adjusting the classroom requirements to reduce potential spread. So if it's feasible to occur outdoors, certainly that would be encouraged. But I think there are strategies that have already been in place that can support safe practice indoors for some of those things you mentioned.
We have Mr. Raven has a question. I want to make sure we're able to get to him. He's joining us virtually.
Thank you all for the presentation. I'm sure not just the board, but the community as a whole is appreciative of being able to have experts to provide some of this insight. And I have a question, but I just want to make sure that we do kind of summarize a lot of the great points that have already been made thus far. From what I've heard, the highest priority is getting vaccinated. Second to that is that masks really do work when used effectively. I think we mentioned the ability to help mitigate risk of being able to have outside eating in place. And then the one thing that I think we also talked about is that when we're looking at surveillance testing, that not just the sample size, but also, am I getting this right? Also the demographic of who is actually being tested actually matters when we're trying to make sure that we have a kind of a complete picture of a representative of each school. Is that correct?
That is correct.
Okay. So let me ask this, because I think my colleagues have asked just about every question that I could have thought of, but there is one that I do have a question on. And I feel like last year we were dealing with I believe it was considered the alpha, maybe it wasn't that variant at that time, but the alpha variant that we know now. And now we're looking at the Delta variant. And I know that the WHO has, they have their list of what they considered variants on their watch list, and the CDC differentiates that from that a little. But what I'm wondering is, at the beginning of the school year next year, our community is going to expect that we're prepared for also what's coming next, not what's just happening now. And I know that there are still a few other variants that are out there, and I have limited knowledge of that. But I know that with the Gamma and the Lambda, and from what I've read, they are not as transmissible as the Delta that we know. But there has been some research that indicates that some of it may also be a higher level of vaccine resistance. And I just want to kind of get you all's perspective. And I know it's speculative, and I know you all usually base solely on the research that's already been available to you, but kind of speculating, how we can better prepare ourselves for what may or may not be coming as we move into these next variants that will, undoubtedly start to come to us.
So the first thing I'll say is that this is not going away like SARS-CoV-1. This is going to be more like the 2009 influenza pandemic, which is now the circulating strain of flu. So this will be with us for the future. What will mitigate it is higher vaccine coverage, ideally pushing like what we have for measles, 95%. In addition, better therapies, so if people get sick, they don't die, and we certainly have some of those. We now use monoclonal antibodies, which largely keep people out of the hospital. For the high-risk people, we've given it to less than 1% get hospitalized, and we can now use it for post-exposure prophylaxis and better antivirals there. The companies, of course, the vaccine companies are already at work at making booster vaccines that we may need sometime in the future that work against the variants that are somewhat more resistant to vaccines. And Moderna already has one they've tried out that worked against the P1 variant from Brazil and the South African variant. And getting an extra shot gives you better protection, but these even gave you more enhanced. So we'll have that potentially to be able to use. But I don't really see at this point like the Lambda variant becoming widespread, if only because the Delta variant is so much more transmissible. It sort of outcompetes everything else. It's sort of like weeds in your yard. They grow faster than your grass, so you're always pulling them up, and you don't really have to. And so it's pretty much the same thing with Delta. It's outcompeting all the other variants. So although they are here in small numbers, we've not seen them spreading. Looking way into the future, 6 months, a year, 2 years, will there be more variants? What will happen? I think it's very difficult to say, except like flu, we will see probably winter peaks of COVID disease. And again, it'll be the mitigation strategies will be vaccine and masking.
Thank you. And my other question is also going to be around dealing with new, evolving, and emerging technologies. I'm curious as to whether you all have any insight to new testing, rapid testing that can literally be able to be used with new digital devices. I've heard just some inkling of new devices that they are trying to create, but just from you all's expert opinion, do you think we're looking at like at least a year type of rollout before we really have the ability to quickly be able to test?
Well, there are two issues with that. One is to develop technologies that are easier for people to use at home, and we're already seeing some home kits, but they're not quite as accurate. And then the other problem is just the companies, as you're well aware of everything from transistors and chips that go in cars to, in the past, toilet paper. The whole world is having a supply chain issue. And so maintaining the supplies for adequate testing are a separate problem. And the focus of most companies right now is just maintaining adequate testing, particularly stressed as they are with the current surge. But separate from that, they are hard at work at developing faster, easier, cheaper testing strategies. And I do think those will continue to be developed and implemented over the next 6 months to a year. Again, I just can't predict, when and how quickly you'll see things, because the major focus of the companies is just maintaining enough supply to keep our current testing going.
That makes perfect sense. Thank you both.
I want to say thank you to Dr. Weber and Dr. Abukum for coming today and giving us this presentation and this information. This meeting was just for information, so it was able to give us a lot to think on and consider. I want to say one of the things I'm taking away from this meeting is engaging with our community, with our employees, to make sure that they are with us as we move towards this. So I think I want us as a board to really have that, keep that in mind, along with all the other mitigation strategies. We need to make sure we're in dialogue with our staff, so we're moving together with whatever might come next. So I want to thank you all for the presentation.
Thank you very much for inviting us, and we're certainly happy to come back if we can ever be of help.
Thank you. The next item on our agenda, board, we actually need to postpone to our work session in September. It was to talk about proposed pay scale differences. For any of our bus drivers who are listening, please know that we hear you. We are working really hard and diligently to make changes to make sure that we can support you and the transportation needs that we have with our district. But we do need to move that item to our September work session. Dr. Ubinger?
I think if I can just complete our chair, because this is a special call meeting, we have a specific item that we're going to discuss. Therefore, we could not add another one. But I'll say this to our drivers. I met with them this morning. Our board is ready to act on these documents. So it's just a matter of a week or two. They just need to be patient, and we should be able to act on that soon.
Madam Chair, can I speak? I want to address some of the things that we're hearing about COVID-19 in school, since this is the special session about that. There's a lot of questions about if we can go virtual. If we could just, switch like we did in the spring, and go virtual. And I just kind of wanted to address that. And our lawyer, Ken Sue, is on as well, so he can help answer this. I'm aware that there's like a petition now to get the board, us, to send us to go virtual as well. And I wanted to address that since there seems to be some misinformation. So in the spring, there was a special provision by the state legislature to allow schools to teach virtually. Well, actually the entire last year to teach virtually. And DPS stepped up. We did the one-to-one technology. We did hotspots and so forth. But this year, that provision is not there. We don't have the ability to make the decision as a school district to just straight go virtual. In fact, there was a law now that was signed into law by Governor Cooper, that within it, there's a general statute 115C-84-3 that only allows the superintendent to make day-to-day decisions for temporary virtual learning if, their school personnel is out because of COVID, or you can't run a school like we should safely temporarily. So we can't make a decision overall. And I wanted to see if Mr. Sue could chime in a little bit more, because I think this is something that could be addressed very clearly to maybe help to end the conversation, or the questions, not necessarily in conversation, but in questions that may be out there about why we as a school board can't just make a decision to go virtual like we did last year, and help some of the parents understand a little better of where we are.
Mr. Sue, I know you're joining us virtually. Do you want to chime in here?
I'd be glad to do that. As we know, the Durham Public Schools Board of Education was a leader in taking the precaution of going remote early on. At that time, there wasn't specific legislation restricting your authority to do that. And as you know, for most of that period that you were remote, you had authorization under the governor's order and DHHS's limitations to have a plan A, plan B, or plan C. That no longer exists. You don't have specific authorization through DHHS's Communicable Diseases Control Authority. And now this new bill has changed and added a new statute that addresses remote instruction. So apart from approved virtual academies, there are very limited circumstances in which boards of education are authorized by law to have remote instruction. One of the sets is there's very limited, and it depends on whether you have an exemption or not, but only for severe weather conditions, energy shortages, power failures, or other emergency situations. So that's one set that says you can have up to 5 days or up to 15 if you have a special exemption. But there's a separate provision that deals solely with COVID-19. And it says that the only basis on which a school system can go remote to address COVID-19 emergencies is when there is insufficient school personnel or student quarantines that require it. It has to be done on a classroom by classroom or school by school basis. It requires reporting to the Department of Public Instruction. And then it says that the school district shall return to in-person instruction as soon as personnel are available or the required quarantines are complete. So back when you made your decision before to protect the health of the community. You didn't have a specific statutory restriction as of yesterday, and the statute is effective immediately on ratification and signature by the governor. You do have a restriction, and those are the limitations.
Thank you, Mr. Sue. I appreciate that explanation. Thank you, Madam Chair.
So, Mr. Sue, does the governor still have that authority, or has that been stripped from the governor as well by this General Assembly?
I should be, I don't think so. I'm not 100% certain, but I think that the governor still has the ability, working with DHHS, to do what is necessary to control communicable disease outbreaks, including COVID-19. So if the governor stepped back in and DHHS said under its authority, or as even the new statutes recognize, the Department of Health retains its authority to make communicable disease control decisions, I think the authority is still there. It's just not exercised at the moment. I mean, as you know, the Plan A, B, and C were removed from the toolkit. Was it late March, early April? I think that if the governor found that that was appropriate, and DHHS found that that was appropriate to be put back in, but it's not there right now. Could be wrong about that. I was just studying it from the board authority angle.
Oh, I appreciate that clarification. I do empathize with our families that feel caught and trapped, because we did plan for a virtual option. We planned far in advance, received a school number, hired staff, and then Delta came and changed their level of risk assessment for their personal family. So it is very much something that I feel like we need to continue to creatively solve with our families. And then, we've watched schools through Florida, schools through Alabama, through Mississippi closing exactly for these reasons. They don't have staff and substitutes to cover instruction and to cover it safely. So, yeah, this is a sticky statute, and not one that actually puts the local authority where it would best be served in public health interest.
Administration, I'm sorry I didn't send this in advance to prepare you, but we're getting the data out in the community. I'm a parent of 3. Are you able to be frank with us today? How close are we to needing to execute one of these remote weeks or months because of staffing? Are we close at a given school, a given couple schools, or are we trending towards we're going to need to do that in a couple of weeks? What is your administration seeing?
Thank you for that particular question. Frankly, we have not got to that point where we have, it's alarming when it comes to school personnel, but it's alarming a little bit when it comes to bus drivers. That's why you've been seeing all these delays with bus drivers, with our buses. That's the reason why I was going to bring you that recommendation. That's the area that we are really concerned. But when it comes to teachers, I think we are still in a good place. But at any point when we are really concerned, that's something that I will definitely bring to your attention, but we are not at that point yet.
Ms. Lewis.
Still speaking about the vaccinations, I definitely appreciate just hearing this information and just move to figuring out a plan of action with the vaccinations. I know at our last board meeting, we talked about voluntarily sharing how many of staff is educated. Is there a time frame when this will have this information? Has there been given a time frame for this action? Just seeing how close we are to getting to that place.
I don't think we set a time frame at our last meeting, but I do want to make sure that we give the administration the time they need to do this well, and also manage the many responsibilities of running our school district. So I don't know, Dr. Mbing, if you have anything to add there. but that's, I don't, we didn't give a time frame, but I know that they are working on that as long with many of the other challenges.
All right, Madam Chair, let me just clarify something that they just whispered to me. We're not seeing any issues with bus drivers with COVID cases. It's just the shortage of bus drivers. That's what we are really addressing at this point. So I just wanted to be specific with that. To Board Member Lewis' question, I think last board meeting, we heard your intentions. That's why we brought all these doctors to come speak to us. But I think depending on the direction that you guys are gonna give us, I will suggest this. We just need to get to the point where we need to collect data first. I think with collecting data, whether or not our staff are vaccinated, that's going to help us a little bit. Let me just be specific, giving an example. If we have 70% of our staff are vaccinated, which we don't know yet, it may be, if I can have the freedom to say this, it may be just some incentive to be able to get another 10% to get there at 80%. If we have about 50% that are vaccinated, that's alarming. We really need to do a better job of maybe mandated, because we really want to get to 80% or higher. So I was able to work with my staff to say, at any point when our board will come say, we really want to mandate this. We really want to start getting our data, collecting data. How are we going to get data? Are we going to mandate for staff to tell us the status of vaccinations? That's where I would like Kensu to jump in and be able to direct us if we get to that point, if it's going to be the pleasure of the board. We have to make decision here to be data-driven, because it's not going to help us if we have 80% of folks already vaccinated, then we want to mandate that. And you know that we're going to have all these religious, medical exceptions and all that kind of stuff. So data should be able to drive how we're going to make this decision. Again, I'd love for Kensu to jump in to be able to help us how, if that's going to be the pleasure of the board, whether or not we need to start collecting those data.
Did you not get clarity from this board previously? And maybe I was at a different meeting, that we were going to start collecting that data already. Like, I thought we left here with that understanding last week. Is that still not, is that still questionable, or do we need to vote that or take official action? Do we need Kensu?
Mr. Sue might correct me, I don't think we need official action, but we did ask the administration to start the process. And so I think we do, this was 4 days ago. So we do need to give them the time to make sure that they can start the process and have the conversation with the data. So yeah, I don't know if you had anything to add, Dr. Mulvaney.
Just wanted to clarify, when we had last board meeting, we did not really get a clear direction whether or not we were supposed to mandate the collection of data. So that was not my understanding.
No, it wasn't mandating that. It was, for me, it was getting a plan. And what you shared as far as what your staff is doing to get a plan and why the data is so important satisfies the question that I answered. So thank you for that. I don't know, you mentioned Mr. Sue speaking about the impact. I don't know if he still wanted to say anything. But again, I just want to make sure, like Chair Umstead has been saying the entire time, we want to make sure that our educators, staff, they're coming along with us in this. Data is going to be important. I know, like you said, it's been 4 days. There's been a lot of needs in general with returning to school and the situation with our bus drivers. So I appreciate you giving an update to where that plan is and why it's important.
Mr. Sue, do we still have you?
Yes, I'm sorry. There was a cat involved among them. So I might have missed the question, but I will say that I know your staff is already working on a process for collecting information about vaccination rates. I talked to Dr. Lassane today about that. So I think that that's underway. And it's, as I said at the last meeting, that's certainly something that you can do. And then if you move to the next phase of a mandate, there are many considerations to take into account. Many of them, I thought Dr. Weber did an outstanding job of explaining. And one of them, of course, is, a mandate implies consequences, and you have to be careful about applying consequences, particularly if you have groups that for many legitimate reasons are reluctant to be vaccinated or have lower rates of vaccination. Are you disadvantaging them? That can be a potential issue. So there are many details to work out before you get to that phase. I know, as Dr. Weber also said, it sounds like UNC has a very sophisticated process for addressing exemptions, which is not the only thing that you have to consider, but they have a lot of experience doing it, a lot of experience as a governmental entity doing it. And their model will be an important one for us to look to if we move to that level.
Yeah. So I feel like I know we feel urgency around this, but I also feel like we need to do it right in order to make sure that we can protect our staff, keep the good folks that we have in DPS. And so I know last Thursday, I feel like we were ready, like, let's go today, but we need to take our time and do this right to make sure, again, that we can bring staff along with us, that we have processes in place for exemptions and that kind of thing. So I want us to make sure we take our time and do it right. With that being said, we all strongly encourage everyone to get vaccinated. If you are not vaccinated, and you'll keep hearing this board talk about how important that is for you to get your shots. And so I know there'll be more information provided this earlier. I feel like the doctors did a great job talking about vaccinations, but we strongly, strongly encourage everyone to get vaccinated. It's so important.
And I don't want to minimize the work and the process and the need to do it right. We should do it right. In Durham, in Orange, in Chapel Hill, we will do it right, right? But the rest of the state looks to us eventually, and they look to the ABC Science Collaborative, and they follow that. That is the only reason these other rural districts are starting to put masks back on children's faces. So I feel that urgency, not only on behalf of our own students, families, and educators, our staff, to start that ball rolling, to tell our families we are collective in this data. We are incentivizing our employees who have done it long ago to report it, and those that still need questions answered, we're going to help you. But I look forward to moving as rapidly as we can. I appreciate that Duke set a date. I appreciate that Chapel Hill has set a date, because it gives folks, okay, I've got to go ahead and do that. And I'm going to get a paid day off if I need it for whatever. We're going to help with the logistics, but we're going to help our people keep themselves and their families safe. And we've got these children in our care. This vaccine for these children under 12 is not coming as soon as we wished it were. So that's the urgency that I'm bringing to this conversation, and that I hope that with all the logistics of school, which are numerous, that this also will get that attention as we move forward. Yeah, because it's so important.
Chair Umstead, this is Board Member Raven. I would like to second Ms. Byer on that. Of course, this is just in general conversation, but I do feel that we do have some sense of urgency. And I know that the administration is working on a manner to kind of collect that data. And I would also like us to move forward and also ask the administration to at least prepare a plan that they think is feasible to offer an incentive to our staff in regards to getting vaccinated. So I just like to go ahead and make that official request, that we ask for them to present that as well, so that, hopefully by the next board meeting when we're discussing that, we could also engage them on what the appropriate incentive could be to our staff. Thank you.
And I just want to remind the administration and our community that the board did, provide some direction to the administration around eating outdoors, and understanding that's complex, but we heard the data tonight and the recommendation from the ABC Collaborative.
Yes, well noted.
With that being said, thank you all for being here at this specially called meeting today. We'll resume conversations at our work session September 8th.
I'm concerned about our bus drivers. I know we talked about them a little bit. Can we clarify that when we take action next week, we could make that retroactive to this meeting? If it's just the logistics of this, Mr. Sue or somebody not letting us add this to the agenda tonight, can we give them that assurance?
That is okay with me. So we'll make a motion when we do this in September at the 8th meeting to make sure we do it retroactively to start from this date. And it is legally that we need to keep to the notice of what our meeting was announced for today.
That's totally my fault.
It is. All right, with that being said, no other questions. We are adjourned. Thank you all for joining us tonight.